So our next speaker is Dr. Daniel Yeoh. Dan will be providing an update on the advice about CMV in children. Dan is a paediatrician and infectious diseases physician at Perth Children's Hospital with a clinical and research interest in infections in immunocompromised hosts. He completed his PhD studies in 2024. His ongoing research focus is on improving diagnosis, optimising prophylaxis and exploring novel treatment approaches for severe infections in immunocompromised children. Please join me in welcoming Dan to the stage.
Just like to, again, echo my previous speakers saying thank you to Therapeutic Guidelines for the opportunity to talk today, and just saying I also thoroughly enjoyed and learnt a lot from the process of being in this group, which was my first time being involved in this aspect of the guidelines. And so thank you to, I guess, all of the reviewers in the group. I'm just going to talk a little bit today, I guess, following on from Tina about CMV management in immunocompromised children. I think talking about management and prevention, and then just touching on perinatal CMV, which sort of got snuck onto the end of this chapter as well. So I think, as Tina said, we know that CMV can cause significant problems and disease, particularly in sort of bone marrow transplant and solid organ transplant. And broadly speaking, I mean, I think we know that it's a significant contributor. This is Australian bone marrow transplant registry data, and you can see in the purple there that in as far as infection-related mortality, that viruses are a real contributor there. And when we talk about viruses in that setting, really sort of CMV is the most problematic. And this is Japanese data, but sort of mirrored in our Australian data as well when we looked. And I think, again, using the structure that Tina sort of alluded to, we really talk about a preemptive approach in most Australian paediatric centres when we talk about sort of addressing CMV. So monitoring CMV DNA levels and then sort of preemptively treating infection prior to sort of end organ disease being present. And I think this is sort of the first time we've included recommendations for children. This is an adult-focused review, but really reflects what we've put in the guidelines based on the data that's out there. And so I think in the setting of a CMV infection, we sort of recommend ganciclovir or valganciclovir and included dosing for that in children. I'll just mention that the dosing is sort of uncertain, as is often the case in children, and there is sort of ongoing studies led by Amanda Gui looking at ganciclovir dose optimization, and then also sort of looking at sort of valganciclovir as part of that as well. I think she's still working towards that. I don't know if Amanda's in the room, but hopefully she'll be able to field any questions about that if there are any. And then I guess foscarnet being the alternative, particularly where there's concern, say for example pre-engraftment in the stem cell transplant setting, where the marrow suppression associated with ganciclovir or valganciclovir is of concern. And for CMV disease, the treatment recommendations are the same, sort of favouring GAN or valganciclovir and using foscarnet as an alternative. We do talk about resistant refractory disease or resistant refractory infection in children, and probably the most common sort of mutation we see is in UL97, which sort of, rules out ganciclovir and valganciclovir. And similar to the adult recommendations, we do include foscarnet as the first-line option in that setting. I guess the challenge in children is, again, we've got less data than in adults, and so you can see that cidofovir is also listed as an agent there where there's issues with foscarnet, although I think practically speaking foscarnet's usually sort of precluded by nephrotoxicity, and cidofovir can also have similar problems. So we really do have sort of limited options sometimes where we're dealing with resistant refractory CMV in children who don't respond. And we've got a tiny line there at the bottom, if you can see, referring to sort of expert advice, sorry Crispin, I guess in the setting of a lack of other options. And so I think this is the Solstice trial, I think, that Tina referenced, and showing that compared with investigator-initiated therapy, that Maribavir was superior in terms of response and was also very well tolerated. This is a trial in adults. And so this is sort of the basis of the TGA listing, which is only for adults. Sneakily, the PBS listing doesn't have an age, so technically you probably could use it in children, but I think we have, when we reached for this, gone to our Drugs and Therapeutics Committee and had to apply because it would be off-licence use. Thankfully, there is an ongoing study looking at PK/PD, including a liquid formulation in younger children, and this is open at a couple of Australian centres as well as sort of internationally. And as I understand it, the adolescent group has almost near completed recruitment, and the paediatric subgroups are still recruiting. So hopefully we'll have some answers around sort of optimal dosing, safety and tolerability that will guide, I guess, future recommendations in this space. This is not sort of a big part of the guidelines, but we have used compassionate access adoptive immunotherapy, and this is data from QIMR, which is one of the big suppliers in Australia, where sort of healthy donors are screened, and then in vitro virus-specific T cells are expanded, then stored, and then matched to, I guess, patients when required. And actually, when we look at this for children, there's a reasonable amount of data, I guess, in terms of proportion compared with overall. Almost half of the patients in this sort of 15-year paper were children, and most of the patients overall were stem cell transplant patients. And promisingly, I guess, where clinical outcomes are reported, there was a positive outcome in the majority there, and these are in patients with very difficult to treat, I guess, viruses, including predominantly CMV in this case. So whilst we acknowledge that preemptive treatment is the approach that's preferred, as Brendan alluded to, we do also talk about antiviral prophylaxis, so I guess universal prophylaxis before CMV infection. And based on the MARDI trial, which was in adults, we know that, again, different set of guidelines, EASL guidelines have recommended letermovir as prophylaxis, and that's sort of been reflected in the adult recommendations. And as of the most recent update of the EASL guidelines, this is EASL 10, and it's reflected in the other international guidelines, there's also a recommendation now to consider letermovir prophylaxis in children. And this is based not on randomised trials in children, but the results from adult trials that show less clinically significant CMV as well as a mortality benefit, and then sort of pharmacokinetic data from adolescents as well as younger children. And in these trials, or these studies, sorry, the rate of clinically significant CMV was 24% in 28 adolescents in the adolescent study, and then amongst sort of the 56 children in the larger study in 3 age groups, I think overall failure was 25%, and of that only 11% was clinically significant CMV. Importantly, letermovir was really well tolerated with only 2 serious adverse effects, which were both considered multifactorial. So based on that, as Brendan said, the FDA have approved this for children from 6 months undergoing stem cell transplant, and also sort of for kidney transplant patients, adolescent kidney transplant patients from 12 years of age. And they've sort of included dosing based on that PK data, both oral and intravenous. The challenge for us, I think, as we've spoken about today, is how do we implement this in real life, considering costs. And I think that's one of the strengths of this TG update, is that we've looked at evidence gaps, and actually this is some preliminary data from Gab Hausler at Royal Children's Hospital looking at CMV reactivation in stem cell transplant patients there, and we've contributed some data from Perth, trying to define, I guess, the high-risk groups, and sort of this is ongoing analysis, and hopefully from this we'll be able to make some more solid advice around which high-risk groups to prioritise this relatively expensive, I guess, intervention to. I guess following on from this, Gab's actually also looking at an observational study with multiple sites using target trial emulation to try and, I guess, look at the efficacy of letermovir prophylaxis, because there's variation in paediatric practice internationally because of that uncertainty around sort of, I guess, paediatric efficacy. But unfortunately, the big Children's Oncology Group trial it's been stopped because of the FDA approval, and it's seen as unethical to carry on with that. But hopefully we'll be able to get some idea about efficacy as well as cost effectiveness from that study. So we do have letermovir dosing sort of for stem cell transplant, and then also for kidney transplant patients. And I think I won't go over this too much, but we do also mention perinatal CMV. We're not trying to, congenital CMV. We're not trying to reinvent the wheel in that there are these ASID guidelines, and we do refer to that. The only slight difference is that we've sort of included reference to valacyclovir during pregnancy to prevent sort of vertical transmission of CMV for mothers who have primary CMV infection, and sort of some data suggests that there's a reduction in CMV transfer to unborn babies when mum has a primary CMV infection with valacyclovir during pregnancy. Just nice to have been part of this, and great to see this finished product with now recommendations for children, including sort of letermovir dosing, and then sort of referencing that new advice regarding congenital CMV infection as well.
Thanks so much, Dan. We've got time for one or two questions. Does anyone have a question for Tina or Dan about CMV?
Thank you so much for the presentation. I'm a new trainee, so I just wanted to ask, do you ever use CMV interferon gamma assay to risk stratify what are the risks of, having a CMV disease in transplanted patient? And other than this CMV-specific T-cell therapy, have you ever used CMV-specific immunoglobulin as an adjunctive therapy in refractory cases?
So two good questions. I'll answer the first and then ask Dan to give his opinion also. So regarding the CMV, something like your IGRA, effectively. So there's a number of different assays available, but it's effectively measuring a very specific arm of the immune system response to CMV. To my knowledge, there is one area where this has reasonably good evidence for its use, and lots of areas where it's used without necessarily good evidence. And so the one area where there is quite good evidence is in your solid organ transplant recipients who are either recipient positive or donor and recipient positive. So the recipient basically has some existing immunity to CMV. The CMV IGRA has been used during the period of primary prophylaxis, so early post-transplant, to guide stopping prophylaxis early. So this group of patients will usually get about 3 months of prophylaxis. There's one quite good study looking at doing regular CMV IGRAs, and when it becomes positive, using that to stop therapy, and they looked at the reactivation rates in those groups. We do have a CMV IGRA available at my centre, and we do use it sort of sporadically. I personally don't find it that useful. I have patients that have negative IGRA, and they don't react, they don't relapse. I have patients that have got a positive IGRA or reactive, and they do relapse. Probably the situation I find it most useful is where you get an indeterminate response. So they haven't responded to the mitogen, and that I think gives you a better indication that they're probably at high risk. You like to keep things simple, and I'm a very strong advocate for just using the regular old lymphocyte count. Brad Gardner did a fantastic paper at this and looked at patients, solid organ transplant recipients who are at higher risk of relapse, and he found that less than a total lymphocyte count of 0.8 was put them at much higher risk. So we have that on every single blood test you get for a patient. So I would use that. Dan, I'm not sure in paediatrics whether...
Again, not a huge amount of data, and I think we found it not terribly useful because sometimes you want to stop prophylaxis, but then it's sort of negative and it's hard to know what that means, at least in children. And I think, again, a plug for data, and I think as part of Gab's sort of analysis, that's going to be part of it, trying to understand what other things we can look at in the bigger picture to define sort of, when to stop or when to start.
And the second question was about CMV-specific immune globulin. And just quickly, there's really not a lot of evidence for that. The group that there's probably been used in the past has been CMV pneumonitis in lung transplant. That's a very, very sick group of patients with very high mortality, and sort of some observational data for that. I personally don't use it, and I don't think there's good data for it. There is data for using immune globulin when people meet the criteria, so that's usually an IgG less than 5, 0.5? I can't remember off the top of my head. But anyway, there's data for that, but not specifically for CMV.